Hello.
Hello.
Welcome. We got a few more people here. I think, did we have 15 or so RSVP, Sunita, did it say?
Let me just double check.
I can't change my Zoom name. It says Jared, but not here, of course. I'm using my partner's computer right now.
Someone must know how to change your name. It's in like your preferences or your profile or something like that.
If you look to the top of right in your picture, there's 3 dots next to the mute button up there. If you click those 3 dots, there should be a rename option.
There we go.
Yeah.
Nice.
Got it. Thank you.
Hey, Matt, I'm not going to introduce you because I want these guys to sweat a little bit over the diagnosis. I don't want them to be like, oh, well, I'm not going to say anything because there's a dermatologist in the room. So you'll be the phone call. You're like, oh, we don't know the answer. We need to call for some help.
Oh, one quick thing, Ian.
Yeah.
You might notice my texts are very short. I've switched to a flip phone and it's very hard to text on these 90s styles flip phones.
There's a story behind that. We have time for the flip phone story. What's the flip phone story?
So the flip phone story is basically being more in the present, mindfulness. I was so distracted with the other phone that it was taking over my life. So I'm kind of like, I sold my old phone and I'm going back to the 90s. But you know what's awesome? This is ideal for long-term care dermatology. It's geriatric style buttons. The noise is so obnoxious that any age can actually hear it, even a 90-year-old. And has like no memory. It's perfect.
All right, no problem. And so when the next time I see you, I want to report out on whether it really did change your life.
I'm on week 6. It's pretty awesome.
Okay, all right. It's pretty awesome. All right. I think I read a blog of someone else doing that. And I don't remember the upside, but I think they eventually went back because it was just too much inconvenience. Like there's just too much that you have to do on your phone, like reservations and, weird stuff when you're at restaurants or traveling, or he was getting too disconnected from people. Yeah.
I can totally appreciate that.
Yeah.
It's an interesting comment, Ian, because we were recently traveling and a lot of the things that you're expected to do, you have to have on your phone.
Yeah.
You go through an airport, you go through security, you got to get these QR codes, you get a visa, it comes on your phone. They don't really give you much of an option to do it another way. So yeah, we were talking about it, we were kind of precludes seniors from traveling almost, or it certainly discourages them.
Exactly.
Seniors more senior than me, but
you almost need an emergency phone just to keep in the safe for travel and just bring it out just for those instances.
Yeah. Problem is you have to remember how to use it when you pull it out. Flip phones are way easier, way easier.
They really are.
Everyone's out enjoying the sunshine. They're not coming back for our meeting.
I put in the chat the people that had accepted that are not yet here.
Is that quite a few, Sunita? Or?
There's about 6 names still. There was Christine Rowe, Lindsay Waterman, Emma Jones, Matt Vaughn, and Dale Nickel.
Do you want to text a couple of them and see? Do you have some numbers? See if they're planning on coming?
I have Matt's number. I can look up the other ones.
Okay.
So while we're waiting for a few more, Ian, this document, the polypharmacy and long-term care,
Yeah.
is great. And I see it's been passed by the South Island LTCMAC.
No, it hasn't. No, it hasn't.
Okay.
Yeah.
Draft.
Endorsed. Is
Not
that?
No, not even seen.
Oh,
No. Was that in gray text? I tried to put it in gray text so that people would know that it wasn't.
no, it came out as, looks like gospel truth.
Oh,
Okay.
sorry. That was definitely me. That's the standardized group that we have been putting on all of these guidelines. That's
Okay.
the intention for them to go through the group a few times and then be endorsed by
Okay.
SMAC. But
All right.
no, definitely not yet.
So this is still a draft then.
Very draft.
Yeah.
First draft.
Okay.
First draft.
I mean, I see the draft background, but it's just that I was looking at this and it looked like it had already been endorsed.
No, so throw your comments on by pencil, pen, or electronic, or set up some time with me or Jessica and
Mhm.
give us your feedback. Okay, 7 minutes. I'll get
Sorry, I'm
started.
just gathering the numbers.
That's fine. I'll get started for Mike and Christine and Clinton Baker. What's your first name?
David,
David. That's what I thought.
hey, David.
That was my
There I am. Good evening, everyone.
good evening. So what I've got going on is a screen to share, and it is very rough. I've just got pictures with no information, so it's up to us to figure out what it is. And the goal is to sort of talk about how you figure out what lesions or what dermatitises are. Not so much get the answer, but sort of the process of getting there, and then maybe some of the treatment if we come up with it. I'll maybe put some notes in the bottom here. We'll figure it out. So they're in no particular order except for this, and then I did want to take a look at that pharmacy document. So these are all pictures of patients of mine, and it turns out I take a lot of pictures of legs. So hopefully we will develop a process of assessing a leg with a lesion on it. As I'm glancing through these, I'm like, oh, gee, these are not good ones to start with, but we'll give it a try. So what things come to mind when you see that? Maybe you get the phone call, oh, doctor, please see this patient because their leg's all purple and they have like a weeping wound.
Venostasis.
That's what it looks like to me too. Yeah.
Right, yeah. And there's some criteria for venous stasis. I guess purple and lower leg, and then it's got this killer, what's this sign called? Where it's got that big dent. There's a word for that. I don't know. We'll think about that. Venous stasis and treatment.
Well, usually compression stockings if they'll tolerate them and if the staff have the time to put them on.
Yeah. And you would do that without ultrasounds, which freak everyone out. Oh no, we didn't ultrasound them. Or are you an ultrasound first kind of guy?
No, generally. Well, in my own practice, I would maybe have done if I was concerned about it, arterial supply. But I think in the population I'm dealing with now, I likely, if I was not concerned about arterial supply clinically, I would not do an ultrasound. I would just progress on to compression.
Yeah, and I've decided, I don't know, heard that under 15 milligrams of mercury, you're fine. So
Yeah.
those diabetic socks and stuff like that
Mhm.
are just fine. Okay, we'll move on because there's some other things to say about venous stasis, but they might come up. Kind of the same deal, yeah?
Yeah.
Compression should help these wounds that keep showing up. And this one's a little pinker. right? This one's very like
Foolish.
purple, dusky. And this one's super pink. So let's say someone said, let's say they're complaining of pain or burning with that. And the scale, the nurses are worried about this scale. They don't like it. They want to know what to do about it. Thoughts about that? For the burning?
Sometimes I find that like a good moisturizing cream, like CeraVe cream, works well.
Yeah. Might help get some of these scales off if it's really bugging them. I would be okay with Betaderm or the stasis dermatitis that I would see there. I wonder if there's another one that's even, no, this one's probably the reddest. And even more scale. I think some of these super scaly ones, the nurses were sort of gently scrubbing them off. I think it was with water mostly,
Mhm.
because they would eventually come off.
It almost looks like a cradle cap dermatitis where you can just,
Right,
you put some sort of moisturizer on, like Christine was saying, and wait for
right.
that to take effect and then gradually sort of work it off. It seems to be pretty time consuming, I think, to do that. The biggest
Yeah.
problem I found with all of these ones you showed us so far, Ian, is that it's when they it's when they start to sort of leak serous fluid and it just doesn't stop.
Right.
Right, they're constantly having to wrap it in bandages and just
Cast
you know,
wrapping, yeah.
yeah. So then, I mean, the nurses were concerned about the scaling, but they were more concerned about the leakage and the constant nursing time it took to deal with that, and the inconvenience for the resident. So just trying to get the swelling down and to allow it to heal so it seals up seemed to be
Yeah, back to compression.
yeah.
One little thing I like to do also, I find that helps is elevating the leg a little bit above like the level of the heart. It really helps with the circulation. It's not always, especially if they have like hip issues, it might be uncomfortable for them or but that's one little thing. CeraVe works really good. One thing I noticed in the CeraVe is it contains like parabens. Sometimes it depends on the CeraVe product. And some people might have a little bit of a reaction to that. Glaxo base works really good as well. But yeah, a good moisture barrier I always find really helps cleaning or getting things fixed up. And one other thing I like to do, especially with the venous stasis dermatitis, just because I find like the skin down there, it's normally in a region often in the lower legs where you're exposed to a lot of sun over the years. And often for men or women, men wearing shorts, women wearing dresses, there's a lot more photo aging down there. So it's going to be a lot more sensitive with a thinner epidermis, weaker collagen. There's less hyaluronic acid in it. The fibroblasts are quite depleted. The elasticity isn't there anymore. So like if the nurses are a little too aggressive scraping off the scales, it's a lot more easier to get abrasions and for it to rip open. So I would caution the descaling a little bit.
Okay.
Unless they have a lot of experience there.
You mentioned about the elevation. That's always a question for us is like how much elevation is good, like an hour in the morning, an hour in the afternoon or two, because people don't want to be immobilized for long periods of time. But is there any, you have any recommendations or is there any data that supports how much time is effective?
I was asking, getting into a little discussion actually with a wound care nurse around that. And she's suggesting as much as possible, but anything will essentially help. So if the patient even is willing to do it, for an hour in the morning,
Yeah.
something is better than absolutely nothing.
Every little bit counts. Okay, now this was given by Dave. Did you have a question about this one? You saw this guy recently.
Yeah, to be honest, I just had a very quick look through my pictures when you put that appeal out to get some material. To be honest, I can't even remember when I took it. I think it was out at Veterans Memorial Lodge, and I think I can't remember the history, and I think we progressed on to doing impression on that. And my question of you, Ian, in my email was, I guess, was the use of steroids. Whether, what are we going to do with steroids? What advantages to using steroids if maybe can be used alone? So I'd be interested to why would we use a steroid cream?
I think in this case where the person's complaining, in my story vignette that I made up for this, so that they're complaining about burning, then I would be like, oh, well, we could help that sensation of burning. But this one, it barely looks edematous.
Mhm.
It's just venous stasis, and then we're starting to get some ulceration in there of some sort. So steroids didn't really have a point, I don't think, in this one.
Yeah, that's fine. And as I said, I can't really remember the history or what I did for it. It was more just to provide an image for this evening's discussion. Then we can.
Yeah, that's the idea. This one seems different because of lack of swelling. Do you think you all think it's just venous stasis, and if it's not bothering him, you could kind of leave it? I'm not even sure where compression fits in this.
Yeah, that's true. It looks like you may have been scratching it. There may have been,
I see that. Yeah, there's
so that might be.
there's a bit of a wound down here.
Yeah,
You
exactly.
can see the iodine mark that they put on the.
Right.
Oh yeah, I hadn't even spotted that. So.
Or the other thing would be, another one might be because the skin is so thin down there, it's just minor trauma can lead to just scabs and that sort of thing without anything else. Yeah, I don't know.
Yeah. Okay. So then this is sort of quite different than this, I would say, right? So
one thing
something
that
else
could-
seems to be going on here when you've got this very particular edging, very lovely edging. So I start to think infectious. Any other ideas?
Sorry, just to backtrack to number 9, one thing that could be a little bit in the description there could be like lipodermatosclerosis, because you kind of got that inverted champagne bottle sign a little bit there with tapering around the ankle.
Mhm.
Oh, okay. Can you say that long dermatology word again?
Lipodermatosclerosis.
Do we do
And
something different with that for treatment?
so that one you can see in venous disease, venous hypertension and such. You can also see that in sometimes diabetics, and that management is the underlying pathology is a little controversial. Not everyone knows the exact cause, so a little bit trickier to treat and such.
Okay. And for everyone's benefit, Matt Gallus is the lovely family doctor who's been retrained, more trained in dermatology, and he's coming to help us out in long-term care. So that's why he's using the fancy words. We're just using the basic words. Okay, back to this one. Anyone approach this differently? New ideas, new explanations, diagnoses?
So what were the symptoms there, Ian? Was there burning? Was there any complaint?
Like you, it's just a picture in my list of pictures. But we can make up a story of burning. Let's say that. Say the person's complaining of heat, but it's not particularly hot when you touch it. You're just like, I guess it's hotter, but it's not notably.
Okay.
This looks like his leg, right? Just kind of a funny looking one. So there's that trick where you raise the leg up, and if it blanches, goes less red within a minute, then you're thinking cellulitis. But if it stays like that, then you're thinking stasis dermatitis.
Hmm.
Needs more investigation. Matt, any thoughts?
How tender was it?
Not tender at all.
Sometimes even if there's no open wound, doing a little swab on top helps. Was any swab done?
No, no swab done. I never really thought of swabbing just bare skin because you just get all sorts of stuff. But you're saying if it's infectious, you should get something particular.
It's controversial, but what we were taught through Cardiff was swab absolutely everything.
Right.
Because sometimes they're even colonized by MRSA that you'll pick up. And there was one peds derm out at even, I know it's not geriatric, it's pediatric, but at Children's Hospital here, and she told me everything open, closed, she just swabs.
Okay. That's fine.
And it looks like there is a tiny, that little
This thing.
thread. Yeah. Is that some broken skin there?
I think it was where it's like if there was blood, there was like a little more blood for some reason, like hematoma, something like that. That's what it looked like to me.
Like even if there's a little collection of fluid, what I do sometimes is I just take a little syringe and I puncture it and then I swab it.
Right.
Yeah. Okay. This came up quite suddenly, out of nowhere. And then I didn't know what to do about it. I think I put steroids on it and nothing happened. And then I tried antifungals and nothing happened. And then it went away.
Hmm.
Yeah. I think it was non-tender, non-itchy. The nurses were freaked out about it. And it was both shins. Yeah. I didn't know what it was because it's such a weird pattern, right? Just like they were kneeling on something, but the person's bedbound. The fact that I'm going to use the word satellite lesion without actually knowing what it is, do you think that says anything? Where this guy super borders, clear borders, this one super not clear borders?
Unilateral more often infectious, bilateral I think a little bit more systemic.
Right, yeah.
Unilateral unlikely to be, yeah, infectious process.
Yeah, that's right. I remember at the time someone asked me if they had like new drugs or something, and I was like, no new drugs. Okay. So
When in
less.
doubt, biopsy, but I typically like the area below the knee, I avoid biopsying at all, if at all possible. Above knee, it's a lot easier and there's less likely to be consequences. Even a little, like for biopsy, the pathologists here in town like a 5 mil punch biopsy.
Okay.
They get quite critical anything less than 5 mil.
Okay. Let's do a bunch of scabby looking things on the legs.
Or can I just ask a question about the biopsy?
Yeah.
If you do a 5 mil biopsy, Matt, do you put a suture in that, or do you just leave it to heal?
I just throw in a quick suture for two reasons. First reason, first off, it depends if they're like an anticoagulant or not. Often I'll still do it just so they stop bleeding. And 5 mil, it's a little bit bigger. Second reason is from also a financial perspective, because you cannot technically bill a biopsy without a suture for MSP standards.
Okay. Yeah. Okay, thanks.
Those scabby things, that's just scale.
Yeah.
Where does the scale come from, Matt? Why do some of these pictures have so much scale on them?
It's often keratin accumulation that is occurring at the site there, or it could be exudate that's accumulating there.
Right.
One
And
of the
it's
two.
Just a product of too much water in the leg.
Yeah, there's the big one that often well, not fairly often I see in the leg is a diagnosis called stuccal keratosis. And that one, maybe not so much this one, but it's almost like where you get these little white plaques on the knee down, and it can extend to the ankle or even the upper foot. And it's all these little keratin plaques that accumulate down there.
Not this stuff. That's
no,
not white.
no, that's not stuccal keratosis.
Okay.
But yeah.
That's white.
Yeah, that's not stuccal keratosis too much either there.
Okay. Thought I could get one. More white, but still obviously just scale.
It's got like a nyctiosis pattern, almost like fish-like scales, if you notice that.
Right.
And that goes in hand with a little bit more of a stasis dermatitis.
Right. And these, let's see. This might have a little something underneath of it.
Yeah, actinic keratosis, the big ones that you want to worry about on the legs are SCCs, and a common very easy mistake is to sometimes even mix up a seborrheic keratosis on the lower leg with a SCC. Like I had one patient that came in from Emerge and was told that it was a seborrheic, and it was I did a biopsy and it actually came back as an invasive SCC. So it's, seborrheics can mimic a lot, but the big thing is when you see a yellow kind of lesion like that, think actinic, think ruling out SCC, and when in doubt, even dermoscopy. So just having me come in and look under that microscope a little bit, or that magnification, magnifying glass a little bit closer, and I can look in the surrounding area, see if there's any features that would support a biopsy. So like this lesion here, I probably would take a dermatoscope too. And I would be looking for like any vessels that aren't to the visible eye, any pink eccentric areas, anything like that that would support a diagnosis pointing towards an SEC early on.
Okay, how about something like that?
What was the history? How early or when did it come on?
Was a small bump and then slowly got bigger and bigger pretty fast. This guy had a bunch of these. What? I can't remember the word. Molluscum? No. Molluscum contagium? No.
More like a keratoacanthoma, maybe.
Yes, keratocanthoma. Yes.
So keratoacanthomas. So it's tricky if he's got like, that would be very, very unusual, but if he's got them popping up all over,
yeah,
you kind of wonder, should I biopsy them? But if you go by textbook, every keratoacanthoma should technically be removed because there is a risk of SCC.
right.
But it does have that volcano appearance with that central
Little bit,
crater.
yeah. I have some other ones of his somewhere in here.
Yeah.
This is the same guy.
That 100%, yeah, biopsy that.
Yeah.
It's likely a keratoacanthoma, but it's sometimes right at the base when the pathologist looks does that histological section, they actually see some invasive cells.
Okay, biopsy. Back to the punch.
Yeah, I suspect keratoacanthoma biopsy every time.
I have no knowledge of this. Obviously, it looks scary. I don't remember what I did with it. I assume it's the leg.
It's like a cow.
Any thoughts about this? Biopsying even seems weird because you're just going to biopsy like an old wound. Maybe it is just an old wound.
So one thing for wounds and ulcers, chronic ulcers, there is a risk for them to actually transform into an SCC over time. So the border of an old wound, if it's a chronic wound,
Right.
should always be biopsied.
Okay, so don't biopsy the middle, biopsy this little bit over here.
Yeah, the corner.
Okay.
So in the biopsy, do you try and catch the transition?
Yeah.
Yeah.
sometimes the pathologist wants 2 biopsies. But especially with this population, one biopsy the first time.
Yeah.
2 biopsies, when those would actually be helpful. When you're extremely worried about an invasive lesion. So if you think you've got a melanoma in front of you and it's got a very odd shape in 2 different areas, say it's on the ear, high risk region, say it's on the nose, another high risk region, say it's got a really funky shape, take 2 separate biopsies, because one part of the lesion can be normal, or it could, and one portion could be actually abnormal. So one portion could actually be invasive, one portion could actually be in situ.
Mm.
But that's if you have notable asymmetry. For that particular lesion, I don't think you need to do 2 separate biopsies.
I just got the ear up. How would you do a biopsy of that? Sorry for the fuzzy picture, but let's assume it's suddenly red and we can't think of any reason why. It looks like there's some discoloration happening there. I can't explain that.
How long has that been going on for?
Really short, just showed up.
I would give it 2 weeks.
Yeah, I
Take a
think
little swab, give it 2 weeks, see if it resolves.
it did go away by itself.
Sometimes I like to I get a referral in and I like to wait 4 to 6 weeks before I see the patient and it's resolved.
Right. But it's not-
So if the patient is like rushed in way too quickly for a referral, we can't always explain a lot of stuff, but the body just resolves certain things on its own.
Some of those ones on the ear I've seen that, like you say, resolve quickly, seem to be almost like a pressure thing. They just suddenly come up. There's no sign of infection or obvious trauma, but over time they just, as you say, gradually fade away.
Or an arthropod bite, that's a good location, especially during the summer months.
Okay.
And those will resolve over 4 to 6 weeks too. But yeah, I agree with the pressure point. Glasses, if how they're sitting there. If you know, an elderly person's fallen asleep against a chair or something like that. Extremes in temperature.
Wait and see. Don't always jump to it. We're on to face now. These things I couldn't scrape off. They were definitely stuck there. No, I had no idea what they were.
Were they on the tongue as well, Ian?
You can see the tongue looks terrible. It looks all dark and funny looking with like white bits. Let's
Yeah.
assume not, because hopefully I would have checked that or looked all around and past the posterior pharynx kind of business.
Oral lichen planus.
Mhm.
I don't know. Lincoln planus, that's what you said?
Lichen.
Oral lichen planus, yeah. You could actually even take a dermatoscope and see if there's that Wickham striae. But you know what? If you see a white mucosal lesion, it's not a terrible idea to send it off to ENT just to make sure they don't want to do a biopsy. And then what I've had, like Dr. Bartlett, often he'll afterwards rule out, you know, anything malignant, and then he sends them over to me to treat.
How do you send that to ENT?
Just say it's a white mucosal lesion.
Oh, I see. You
Yeah.
describe it. I thought I was gonna try and scrape one of those off.
I would just send them in for a white mucosal lesion and see if they want a biopsy. And if they're 100%, then actually how I would treat it is I put actually a little hydrocortisone on. And that can help get rid of the oral lichen planus and that. But yeah, first one would be rule out. You see an oral mucosal lesion that's white stuck on, just always like to rule out cancer.
So basically that he or she would have to be physically referred to one of the ENTs for them to look at it,
Yeah,
which sometimes is a bit of a challenge in this population.
it's given the diffuse nature of that and how it's pinpoints all over the place. I would say it's highly unlikely to be an oral cancer.
Yeah.
But But yeah, it's something I can definitely take my dermatoscope to, and I can look closer at this one.
Okay, another one what you would think would have a big story to it. I don't remember. She was in my geriatric clinic, so I never saw her again, and I possibly she was off to go see a dermatologist. But it was interesting. Rare, do you have any obvious names for that guy?
Well, it almost looks like a facial mask that got left on too long.
It's
Now
so,
it's peeling off because the skin above the peeling area looks quite good.
yeah,
Yeah.
all fresh and stuff, some sort of exfoliation process that the body's going through,
And
On one side or both sides of the face?
both sides. Yeah. Some sort of like hyperpigmentation, inflammatory thing, and then the body just goes through a whole cycle of growing a bunch of melatonin and then shedding it all off again. But don't know anything about it.
There's a condition where you can get sort of darker pigmentation and patterns on the face called Favre-Rocher syndrome. I don't know too much about that, but that would be worthwhile. I'd have to look into that one a little bit more just because it's so uncommon, but it would
Sure.
actually fit the picture sort of the textbook, Favrerouscher, I think it's called syndrome.
Mhm.
And they've got, yeah, that pigmentation that can appear and in elderly too.
Yeah, I think this is a bit chronic, sort of acute on chronic, lip lesion, painful, worrisome.
Biopsy.
5 inches there though, that's A, gonna hurt, B, bleed like stink, and C, making me feel bad.
I would totally get a dermatoscope out, look at that two things on differential SCC versus BCC.
Right, it's just so screaming cancer right now.
Mhm.
Okay. Any questions before I push on? Christine, Dave? This is supposed to be a picture of what I assumed was the mole. Bad picture. Am I in? Okay.
Oh.
Just so how do you decide that that's benign or just leave it?
No. Yeah, I'd like to know the time course, like how long it's been there. Is it changing?
Not changing. I think it's been there for quite a while. Maybe it got a little more like pronounced, I suppose. That's why he started to notice it.
I think I would use the MAT rule and look at it after another 6 to 8 weeks.
Okay. I think that's what I did, and I think it's
With another picture, yeah, and the pictures are really great too, because if you've got that picture, then you get them back again in 8 weeks' time, and you can show them in fact that it's exactly the same. That's not a cancer. Well, unlikely to be a cancer. Is that fair comment?
Yeah.
it's not red. It has some pigmentation changes,
Mhm.
but it's just I don't know,
Almost
it's
looks a
kind
little
of-
verrucous to me.
Say that again.
Looks a little wart-like, a little.
Mhm.
Yeah, yeah. With the what's the word? Search for the
Verrucoid. Verrucous.
verrucoid.
Yeah.
Verruc-
One thing on there could be like a cutaneous horn, even though they're a little bit more whatchamacallit, dry and scaly, probably I would say. But you could also actually get a verrucoid seborrheic keratosis. So it's a variant of a seborrheic keratosis that mimics a wart a little bit more, but it's a little bit more of a verrucous appearance. And then you can sometimes get almost that red exudate on it as well. So that would also be on the differential. Monitoring this one would be important.
Okay, that was Dave's spread idea. Sticking with the ears, pus coming out of the ear, all that redness. Don't remember what I did. I think I put an antibiotic on it. Maybe I treated it with something for the inside the ear.
How long was it there for?
I was called because there's blood on her pillow. I don't think she was my patient. It was like a torch call.
Oh,
Yeah, in fact, now I remember it. Yeah, Glengarry, Fairfield, B-side. And I worried about it, but it got better. It was actually Rod's patient. He might have done some smart things, but I didn't understand what was going on there at all. It said like just an ear infection, external otitis, just gone crazy.
That is a bad one. I would, yeah, just swab it first and see where it goes after, if it comes back positive after antibiotics after a couple of weeks. You did oral antibiotics, right?
Yeah, I must have. Topical doesn't make any sense, does it?
Yeah. High risk zone. And if there's any lesion remaining after about, I would even say after 2 to 4 weeks, then I would biopsy it, because if there was an entry point, that's the question. Was there an entry point for the organism to enter to begin with?
Right.
And if you have a cancer that's bleeding there already, that could potentially be an entry site.
Okay, so you clean up the infection, but there's still this lingering wound.
And if the lingering wound is still present, then it's quite questionable, and then it should be biopsied.
But Matt, you refer to high risk areas. Could you explain high risk areas? You mentioned nose. You mentioned this is a high risk area. Are they just areas of the body which are more likely to have malignant lesions?
well, sun exposed areas, it seems like.
So the biggest high risk regions for actually metastases. So if you have like an SCC going there, or for poor outcome from a BCC or even a melanoma, ears are really high risk. Nose is very high risk. Periocular is high risk. Those are kind of the big ones. And then the other rule of thumb, high risk, is if it's a recurrent cancer, so even a recurrent BCC at the same site, high risk automatically, and that could be anywhere. So if you have a BCC that, or an SCC that reappears, say on the left side of the chest, after it was initially treated 5 years later, it automatically meets the criteria for high risk. Even though BCC, you don't really see spreading, just for poor outcome.
Okay. So 2 things on the cheek. Would those be considered high risk cheek areas?
No, cheek's not high risk.
No. I don't remember anything about this one. What does it look like?
How long has it been there for?
Don't remember. Yeah. I don't think it was sudden. I think it's not like a wound of any sort or a burn, which kind of that's what it looks like to me. Sort of a worsening, acute on chronic, I'll say, for the sake of the story.
And it looks quite symmetrical to me.
Yeah. Odd, isn't it?
Yeah, it looks based off morphology, you know, like it's well circumscribed, it's symmetrical. You got central hypopigmentation, surrounding erythema. Already I'm not thinking anything like a BCC, SCC, or melanoma just based off the morphology alone. But this is a case where a dermatoscope again would come in handy, just to make sure there's no abnormal vessels for the distribution of the vessels, and just looking at some other atypical features with a dermatoscope.
Okay. This one, sorry for the bad focus, but it's really the problem is here. So pigmented, well circumscribed, very uniform. I wasn't worried about it, but I was wondering if it was growing, and I think I tried to measure it and it never did.
It doesn't look worrisome to me. Of course, always worry, the big thing we always worry about, for brown lesions on the face, lentigo malignant melanoma.
Mhm.
But this one, highly unlikely.
Just too big, too uniform, too,
Uniform.
yeah, too
And it's
uniform.
not changing in size. That's, yeah. Like the rule of thumb for changing in size, 3 to 6 months.
Okay,
So if something's changing rapidly over 3 to 6 months. And like the rule for symmetry, like the big rule I really like is the rule of chaos. If chaos is present or not. So if you look in nature, pretty much everything is symmetrical, a leaf, a tree trunk, your kitchen table, but once it's asymmetrical, not necessarily just in shape, but also if it's just asymmetrical in color, that would meet the criteria for chaos. And since you see that, you should start to become more curious.
something disordered, unnatural is going on, or not intended, not body intended, or something like that. If you'll indulge me, I want to switch gears and just talk about polypharmacy. So I just want to read you or let you read a bit of this. Can you see Word document now?
Yep.
Okay. Or you can just open it up yourself, which it's an attachment. So skip the background. Oh yeah. Pardon me. All right, so it's about polypharmacy. It's from a meeting we had a while ago. And this paragraph I'd like your comment on. As people age, a provider's medical care or medical care practice and the use of medications should adjust. Earlier in life, the practice of medicine endeavors to use medications to extend life and prevent future harm. As a person's frailty and comorbidity increase, they age. Medication's ability in this regard becomes uncertain. While at the same time, there's the increasing possibility of negative outcomes from our medications, such as cognitive impairment, reduction in the person's well-being, injury from falls. And that's why I say, oh, so that's why we need medication reduction, which is unique to the care and long-term care, because the balance of pros and cons has changed. Any comments on that?
I wonder where you said this creates the necessity for medication reduction. I'm just wondering if whether or not saying this creates an opportunity for medication reduction is, I mean, necessity seems more forceful. Is that
Yeah.
your intent?
And I think I'm doing that on purpose. I mean, obviously,
Yeah.
Opportunities, sometimes I find it's like this coded word for, passive aggressive,
Yeah.
coded word for,
Yeah.
Mike, I noticed you're having some trouble with your public speaking. Boy, that creates an opportunity for improvement. I mean, I'm just telling you, you're a terrible public speaker. Then I'm trying to make it sound nice.
True.
You aren't a terrible public speaker. I just picked that at random from my brain. So I want to be forceful.
Yes.
Partially because I was trying to pick up on the tone of the meeting. The meeting
Yes.
this came from was very forceful. It was like, you must do these things. This is where I try and say we're talking about preventative medications and not symptomatic, without just sort of with very specific examples to give people like that context.
Yeah.
Okay, so then I think it's about these 3 steps: goals of care, how much the family wants to be involved, and then start reducing medications, and then things sort of peter out there. So what do you, conversations with residents and families, we've got a little guideline to refer people to about goals of care, and use to understand the person's feelings toward medication, and sort of with this goal of assessing the resident family's willingness to accept new perspectives on preventative medication or measure
so-
future change.
So in keeping with your necessity and above,
Yeah,
should the word, we want to consider the word, instead of can be used, should be used?
sure.
Conversation with residents and families should be used to understand a person's feelings toward medications.
I don't quite understand my second sentence here. This will help with assessing a resident and their family's willingness to accept a new perspective on preventative medication. Sure. Okay, and then or measure future change. Not sure what I was trying to get at there.
Hmm.
Measure future change. Okay, I'll delete it for now. I might have been trying to get at, you have the conversation today and then you have it again and you'll be able to see that their attitude's shifting, but that doesn't seem that important.
Yeah, and I think somewhere down the road, further down, you do mention about it. Well, I think it's the very end thing is, it's a constant activity reducing polypharmacy. So I don't know if that's what you were intending on that one, but I guess it's the idea of, once you start the process is a fluid process. It's ongoing. It's not like I stopped a couple, I've done
Right.
my job for the day,
And yeah, maybe that's what I'd add here is it's not a single conversation.
Yeah.
Like have to have. So I'll just put that in and then we might find a way of doing that.
Mhm.
So I think we have a role of getting residents and family to think differently. But think about that. How much does the resident want to gain more time? So these are questions I would be sort of, how much does your mother or, maybe I might have to rewrite that so it's clear. How much does your loved one want to gain more time with their life? But I think the problem I had is I didn't want to divide it up. Questions you give to the family, questions you give to the resident, like we've done in other goals of care conversations, because it just takes up too much room. So I think I was trying to be like, ask the family, ask the resident to assess whether the resident wants to gain more time in their life. So hopefully that can come through. What is the resident's interest in taking medications on a scale? So this was an idea I had, is think about it on a scale: refusal, resentment, reluctance, acceptance, and appreciation. I don't know if that's a good idea, but it was an idea.
Yeah, I kind of like that idea. Should the word between be different because it's not just two things,
Right.
it's multiple things. Yeah, that looks good. I kind of like the way you phrase it that way, is that it's a, that whole process is a kind of a continuum where you go, or at least there's a continuum of how residents see their medications. And yeah, some of them, as we well know, are very attached to them, regardless of whether they're helping them or not. And others, it's like a fight every day to get things in, particular things in that we think are making a positive difference in their lives. So a lot of this, I think, it got down here is just making sure that you're in tune with the family, or the family at least has a good idea of what the goal is, what helps them to think more clearly about what they feel is the best thing for their loved one, and hopefully aligns with what we as the MRPs think would be best for that resident's quality of life.
Like how you said that, get in tune.
Mhm. Something,
And it looks like it's about life, like their current life, and then their interest and their experience, sort of like the 3 bits that you're trying to get at.
Yeah.
And this is just data. It's used to gather the following information. And then, what are the effects of medication at their stage of frailty? Try and gather this information. Is the patient bedbound? What is the expected benefit of preventive medications? How much care is done by nurses? What is the patient's quality of life? Maybe get some NNT numbers and try and figure out some side effects. So I guess it's trying to think of their frailty relative to the medication that they're taking. Worries about med reduction, life expectancy, and then the studies that they were quoting, we probably need to get links to at that particular meeting.
So just going back into the one where you say, what are the effective medications at their stage of frailty? Is it helpful to, have the frailty scale there or something to frame that so when we talk about frailty, we all have a pretty good idea of what we think frailty is from one end of the spectrum to another. But I think for people who are lay people, they hear the word, but I'm not sure that maybe they think of it in the same way that we do. So, on the one hand, it adds, means adding a bit more to the what you've got down here. But do you think it's worthwhile to try and say, this is the stage this is the stage of frailty I think your loved one is at, or my professional opinion, or whatever?
Yeah, we'll have to think about that, but you're right. This is a guideline for physicians.
Right.
It's not a handout, but I think what I'm trying to do is, sure, we have the frailty scale, but how does that frailty scale affect our medication decisions?
Right.
So like this is a frailty of 7, bed all the time.
Mm-hmm.
And then, how much care, maybe that's like a 6 or a 5.
Yeah.
That's all I guess I'm getting at, is just sort of where are they?
Yeah.
Yeah.
That's true. So this is for physicians. Are you thinking this also something would be? Some of it looks useful to be, at a nursing station for the nurses to see. But
yeah, all of the stuff we pass out to the nurses too, all of our documents.
Yeah.
Okay. Any other comments, Christine, Dave?
Yes, I guess my comment is that I'm in this sort of stage of my career. I came from my own primary practice like 9 years ago, and I've just been doing initially rural locums, now for the last 3 years, just long-term care work. And all the people that I look after are new to me. I have no backstory on them, no history at all. And oftentimes when they come in on a whole list of medications, they've been told by previous doctors, on your account, should you stop taking your whatever it is, your cholesterol lowering drug, and they take that as a gospel. And it's embedded, often not the resident, but maybe the family, even more so. And it takes a bit of diffusing that to say, well, that advice was given to you, and it was good advice at the time.
Right.
But now things have changed, and I think your loved one who is getting into a new stage, and really the benefits do not exist anymore. And I think it often takes, you've got to build a bit of a relationship first, because it's a relationship from scratch.
Yeah.
For them to trust you, and that's what, so I don't know whether you want to include something You're not that, or whether we all in this sort of chapter of our careers do recognize that.
I was speaking to some senior long-term care leaders at or physicians at a conference a couple of weekends ago, and they didn't mean to impress upon me, but I was suddenly shook by the idea that my job is to build trust with the family. That's like almost job number one. It's really close to job number one. Sure, I need to reduce the symptoms of my patient, but boy, building trust with the family sure helps everyone a lot. And I just totally missed that for the last 8 years. So I'm happy to put trust, something about trust in there. Yeah, it's hard to say that you need it in order to balance the many years of their primary care doctor saying you have to take this medication. But we'll put something like that in there. Christine, any thoughts from you?
No, I think it looks good. I think a good advice I got when I first started long-term care in terms of medication reduction was to look at the person and ask myself, would I ever initiate this medication? So, I would never initiate Crestor on a 92-year-old. So why should I continue it? I think it's very easy to continue things that they're already taking, but yeah, I mean, I would never start statins in a 95-year-old. So that was an easy way to kind of think and look at things differently.
Right. Nice. That chain makes things so that might be like down in here. I might put it down in here. Okay. We'll come back to that another day. Just hit save. Before I lose that. Okay, back to dermatology. Just just a few more slides. I want to get into some cool bits here. I'm going to skip that one because it's not clear enough picture. This one was a spontaneous, like the nurses just said, it just showed up, it just started bleeding. I guess biopsy is, or just leave it.
If it's persistent more than 4 weeks, I'd biopsy it, swab it, biopsy it.
Okay. This one's a fun one. I've never seen this before, but probably all you senior doctors have seen it before.
Gouty tophi.
Yeah, that's what I decided. And I have been treating with allopurinol for a year or two now, and they're all gone.
Yeah.
Wow.
Yeah.
It's interesting when the skin breaks open because the stuff that comes out is like toothpaste. It just kind of oozes out, and then you can send it off, and the lab will identify all out as the
All
gouty.
the uric acid that's in there.
Yeah, exactly.
The next few, because I don't have any pictures of other things that I get so commonly, I stole some pictures from Derm NZ. So what would you guys say this is?
Where is it?
You know the story behind it, Ian?
No, they're just pictures. I do know the diagnosis.
Hmm.
But
Could it be zoster? Is it painful?
It looks
not
like
painful, no pustules or anything like that.
Is it bilateral or unilateral?
I can't even tell. Oh yeah, this is the groin. I see. Yeah, so it's probably bilateral. You can see the redness over there. But this, I'm trying to get at the,
I
we're
think an
constantly called.
inverse psoriasis.
Yeah.
But you also have to roll out infectious things, like Corynebacterium and Atussum. It's got some satellite lesions here as well.
Yeah, I've had in my mind fungal infections always have satellite lesions. Is that a lie?
It's big with Candida, the satellite lesions.
Okay. And that's anything that is like all by itself, little island, all these little islands, basically. If
You
it looks
can't
like
exclusively just say Candida. But especially in the groin, like I have seen a psoriasis, believe it or not, like this as well in the groin or in the anywhere in the flexures. It's just the moisture gets rid of all the scale, so it doesn't present typically.
Mhm.
Oh, I see, right. A psoriasis, okay. Yeah, this is Candida. Okay, so satellite lesions, pink skin sort of on top of pink macular papular business on top of nice skin. And then Candida is pretty much always a moist area.
Inframammary region,
Right.
that's a big
That's
one.
what we call, we get called for under the breast rashes, you know, every month, if not every couple weeks.
Mhm.
And what do you guys use for treatment for under the breast red rash?
Weight loss.
A better bra. No, these people are lying in bed all day.
Well, the first thing is you want to dry it out. I just sent it to you in an email here, Ian. It's a pretty good picture of different vehicles that you can actually use to formulate stuff. So if it's kind of if everyone else wants it, so if you've got issues, you know, with the flexures, axilla, groin, inframammary, you kind of want powders in those particular regions if the pharmacist can formulate it. Yeah, there we are.
Right. People used to have powders in long-term care just before I got there, and then they said they got rid of them.
Powders are really good to take out the moisture and dry.
Interesting. Mike, do you remember the days of powder?
Yeah, and I also remember when they seemed to just disappear, like, yeah. There were some other products like strips of I can't remember what it was that the nurses had.
Oh yeah, Intradry.
Yeah, that put under, especially the inframammary areas where it was so moist, and it would dry it out. When we're trying to avoid the powders, I think people were using not medicated powders in the past, but like talc and that sort of thing. And there were some issues around how really whether that was helping or making things worse. And maybe that's where some of the powders went. But the dusting powders, is there a base that then the pharmacist would add in like an antifungal or an antibacterial to it? Is that how it works?
The idea.
Yeah. I'm not too sure in long-term care the scope of pharmacists of what they can and cannot do. But certainly families can take go outwards to like a compounding pharmacy.
Yeah, my guess is that was what would probably have to happen, because I don't think the pharmacy that we have available to us, at least to the Island Health owned sites, they seem to have very limited ability to get things. So a lot of the other facilities around town that are privately owned, they have to go to their private pharmacy. So so perhaps they could get these things made.
And another one, like I did mention weight loss, not always, of course, the easiest long-term care, but blood sugar control. Often I find, you know, when it's like candida infections, seeing what their A1C is like. And pretty much, you know, like if their A1C is around 11 and they're bedridden, they're going to be on this medication forever. Until you can get things under control a little bit better, which may not happen. So it's often a very difficult conversation to have with a patient, I find, especially when I think one of the big things that one of the major contributors is a poor A1C control. And it's a deep conversation for them to try and accept that you need to reduce the A1C to get better control of the candida infection.
It likes the sugar.
It does.
coming out of the skin.
Well, immunocompromised, yeah.
Right. That's true. So I would be torn between steroids and antifungals, and then maybe just settle on the combo of the two. Is that, where does everyone lie on that?
Yeah, traditionally I've used clotrimazole with, with hydrocortisone to 1%, not half and half, but the clotrimazole and then get the pharmacy to add hydrocortisone to bring it up to hydrocortisone 1%. Is that a reasonable approach, Matt?
Yeah, I wouldn't use any strong steroids in the flexural regions. Even mometasone might be too strong. Always just start with hydrocortisone 1%, 2%. And that applies for any flexural region. Never use beta-derm in a flexure. Way too strong. But yeah, and even if you can get a nice statin powder, but clotrimazole, that's reasonable. I've used that too.
And someone once told me, oh, you're a terrible doctor. You're never supposed to put steroids on Candida because Candida loves to eat steroids, and you're just fueling the fire.
Oh, you've got the antifungal going on at the same time, but you need something for the patient's itch. That's the tricky thing, right?
Mhm.
Okay, how does that distinguish from this dermatologically? Groin, pink, just no satellite lesions.
It's okay with Thrasma.
Is there any fine scale on the border?
Not really. Just do the same treatment. I'd do the same treatment and see if it responds. It's really a diagnosis by treatment.
You don't know whether you're treating from the steroids having the effect or the antifungal, but as long as it gets treated. This is tinea cruis.
With the fine scale on the perimeter.
That's the key bit. Okay. So Candida no scale, tinea scale. Is that the trick?
Yeah, it always though in the perimeter.
Okay. Huh?
So is clotrimazole going to get rid of the tinea, Matt, or not?
It should, if clotrimazole fails, sometimes it does. Then I switch to miconazole.
Yeah.
I go through the antifungals. If I'm 100%, I believe it's tinea. Well, if you go textbook, technically you should do a little skin scrapings as well. Just on the odd occasion, I've only come across it on 2 instances where it was actually a resistant fungal to clotrimazole or miconazole. It was like a rare variant, and that's when they had to go on oral medications. But yeah, for simple, straightforward, and in an ideal world, yeah, you're going to do scrapings. Ideal world, yeah, you're going to do swabs. Ideal world, you're going to take a Woods lamp and you're going to look at it and see what color it fluoresces. But
No, we're not.
we
Woods lamp.
Oh, I've got that in my bag. But then patients wonder why you're taking a Woods lamp, and they're undressing to their underwear in the dark. It's not always practical, to be perfectly honest with you. So using the clotrimazole does save a lot of questions.
And funny looks by family members who are in the bed next door. What is
I've
that
been
guy
there, yeah.
doing? Okay. Doctor, there's red spots in their axilla. Bug bites, scabies.
Mm. It's more like staph.
Folliculitis.
Hidradenitis suppurativa.
I have no idea. I'm just telling you what the website said.
So the hidradenitis, is it usually more florid than this? Or because it seems to be I always thought it was sort of a matter of degree, like you have folliculitis, and then if it was really bad, then we'd be calling it hidradenitis suppurativa.
No,
They're synonymous.
kind of, they're kind of separate, the folliculitis from the HS. Folliculitis, you can get like different variants. You can get, like the bacterial, you can get, like fungal, you can get or sterile folliculitis. But HS goes a little bit more, and it's a separate classification system,
Mhm.
And grading system. And this could be like a very mild form of an HS. I typically see it more in obese individuals. Not always, but typically, and often see it in females. I've rarely come across it in males. And for it to come in a long-term care population just out of the blue, very unlikely. It often manifests, I would say, in your 20s, 30s, 40s. I just throw in the differential for acneiform lesions in the axilla.
Mhm.
Because obviously this is a young person, not an old person.
Mhm.
And treatment for folliculitis, I actually don't know.
Typically, I like to use oral antibiotics. So you can use and it depends on the resistance, and it can be really tricky. 14 days is what I prefer to use. You can use Keflex, you can use cloxacillin, you can use erythromycin, but there's a little bit more resistance to it. You can use doxycycline. Folliculitis, if you can swab it, especially if there's a pustule, very helpful to do a swab of it.
Okay.
Very. I've had patients where I've had to go through 3 different oral antibiotics before we finally came through to a success. But sometimes if the swab is coming back negative and everything is, you look under a dermatoscope, you see it's coming right out of the hair follicle. You've tried all the antibiotics, there's 0 response, then you have to start considering fungal. So then you can trial an antifungal for the folliculitis. And if you get nowhere after doing antibiotics, antifungals, then your worst case scenario is a sterile folliculitis, which is a pain in the arse.
Mm.
Or the axilla.
Right, so
Yeah.
if you're resorting to antifungal, are you resorting to oral or just a topical antifungal?
I would do a topical to start. And then maybe consider, fluconazole later on.
Mhm.
But, fungal folliculitis, it's quite rare. I wouldn't suspect you would see it too often in long-term care.
So this is another groin. It's much beefier red. Doesn't have satellite lesions. Doesn't have a clear border. Doesn't have follicular little red maculopapule bumps. It's worse closer in, and then it kind of peters off.
Yeah. I want a history. I want to know if it's painful or not, itchy or not, if it's on both sides or one side.
Probably both sides. I've never seen it. Have you ever seen anything in the groin that's one-sided? Maybe what does that mean if it's one-sided?
A little bit more infectious.
Mhm.
A woods lamp would be great here again.
You and your woods lamp. Contact irritant dermatitis due to urine.
Hmm.
In an adult. Irritant dermatitis. So that's just barrier cream, like steroids aren't going to help. Fungals aren't going to help. Barrier cream, but then barrier cream sometimes adds, I guess it adds moisture, which is fine as long as there's no fungal infection in there. Would you guys, well, how would you treat that?
Keeping the area dry as possible.
Right, try and remove the contaminant, but urine's hard to not flow in the wrong places.
Reminds me of a patient Michael sent me back, was it February? It turned out in the area, it was actually more of a fecal dermatitis, irritant dermatitis on the opposite end.
Right, yeah.
That was very, almost impossible to treat with that particular patient.
Okay, keep it dry. Mike, anything you would do? Christine, anything you would do?
I keeping it dry is, I mean, the obvious thing to do, but in this population, we know that isn't necessarily all that easy to do. Kind of reminds me of my grandson. It's not easy to keep him dry either. So, and when this once this is here, barriers seem pretty safe. We had a trial of barrier for a while, and on top of trying to keep it dry.
It's nice for me to see the big difference between these two. Do you think it's always that clear? Fungal versus
No.
or candida versus this? No, probably not. Like it could easily be both, right? It's candida plus contact dermatitis.
Mhm.
Yeah. So then you sort of throw everything at it.
The big thing about dermatology, often trial and error. When one cream fails,
Right.
you try another one. And you try to figure it out, with swabs, and especially this younger population, you can do biopsies, but this population, you have to be so careful.
Mhm. Yeah, and some of the things, I guess one of the questions in the back of my mind always is, depending on how frail the person is, what am I going to do with, if I get an answer, what am I going to do with that? Like some of the SCCs and BCCs, as long as they're, so we've certainly taken a wait and see approach, knowing clinically that's what it is, but someone's, significant dementia, relatively short lifespan,
Yeah.
how aggressive are you going to be? So again, we're sort of picking and choosing, your community population, you just go all out. But I think in this group, we're probably doing a lot more watchful waiting, I think.
One big lesson I learned, and a question now I ask every single time I see a patient in long-term care, and this is just through my own experience, is the patient still going to be around when the biopsy returns?
Considering it's going to be 6 months for the biopsy to come back these days.
There were a couple patients that I've done biopsies on, and I've learned that I put the patient through harm. I caused harm on the patient because I couldn't actually fix it. I put them through the biopsy. It was painful, and they were no longer with us when the biopsy returned. So it's I put that question out every single time I see the patient, versus that one that you sent me, Ian, that lovely lady, you take the BCC off her forehead. She's clearly having a birthday party, because I hope it's not back now, but yeah.
Yeah, she's got a lot of spark in her. Sure, she's 90, but like mid-90s, but she acts like she's 60.
Yeah, and that's different, right? So you have your 90-year-old who's bedridden and advanced dementia, and quite often you're either treating the nurse or sometimes a family member. So sometimes you have to stop and have a discussion and say, well, I can look for an answer and tell you what it is if I do this biopsy, but then we have to decide, are we going to do something? Are we going to intervene? And if we're not going to intervene, why do the first step, which is not going to be painless? And sometimes difficult to do for someone who has dementia. You can't explain why you're doing it. They just know you're trying to take a piece of their skin and they don't want you to do that. So
Exactly. Oh, there was one little pearl I wanted to throw in as well. It was sort of connecting a few slides, if it's okay.
Sure.
It sort of connected some slides that we've seen earlier with possible squamous cells on the legs and scale with the polypharmacy and the medications. One thing just to keep on the radar is if a patient has been on hydrochlorothiazide, for a longer duration, they have a 16 times increased risk of developing a squamous cell carcinoma. So, and a lot of these patients are on blood pressure medications. So when I look at the medications and such, I also look at various medications and see risks, you know, like hydrochlorothiazide, and I'm looking, you know, on their body, I'm seeing maybe their risk is a little bit higher. That could be an SEC. Or if a patient is on beta blockers, for example, okay, maybe their risk of a psoriasis is a little bit higher because beta blockers are with that. But always remember medications and possible skin manifestations from cancers to other reversible causes.
yeah, that's a good point, because a lot of the people that we get have been on something like HTZ for like years, decades. It's worked well. I mean, they're now 90 and they started when they were 50, but like you say, that combined with sun exposure and all those things, yeah, that's a good point.
Few things I circled on my notes here. Idea of a Galaxo base sounds like Matt's favorite. Might get rid of some of those scales or just moisturize the legs nicely.
Well, there's another really good one if you can get E45. And it's an emollient. It creates a really nice moisture barrier.
To keep the moisture in and add moisture.
Yeah.
So is that an expensive product, or is it?
I just ordered that one in on Amazon so families could bring it in. It's relatively let's just see what the price is here right now. Amazon E45.
It's just like how it sounds.
Yeah.
Capital E45.
Yeah, it's $23.
Oh, okay.
$22 a cream. But yeah, that particular one creates a really nice moisture barrier. You can get tubes, like big tubes, 125 grams for $12. Yeah.
When you say moisture barrier, what's the difference between that and a moisturizer?
This one's a little bit more of an emollient. So an emollient is a little bit greasier, a little bit slippier, sort of kind of in that chart I sent over, versus a cream. So you break it down. You've got creams, you've got ointments. And I would say emollients are a little bit more on the ointment side. Creams, they go on, they absorb nicely, they're not greasy. Versus ointments, emollients, they're great for dermatitis. They're great for anything that requires a barrier, you know, like maybe venostasis dermatitis, that would be great down there compared to a cream. I wouldn't be using a cream as much. I think like a barrier like E45, emollients like that, ointments, really help keep the moisture in. So think of the skin like brick and mortars. And when you've got a dermatitis, that mortar is gone, you know, so water can leak right through the bricks. So what we're doing with the emollient, with the ointment, we're kind of creating an external barrier so you don't lose all the water.
Okay.
So you're trying to trap moisture. So ideally, it's best put on after, like if the skin's damp, to improve the moisture retention, or does it matter?
That would be a little bit more severe, moderate to severe.
Yeah.
So like if we're looking for best practice for severe dermatitis cases, like severe eczema, like a big one that we see for geriatric population. Another big pearl is eczema crackly. So almost like a winter eczema in that.
Mm.
What I often tell the patients is don't have any irritants on whatsoever, no colognes, no fragrant soaps, have cold baths and pat dry. Don't rub the skin. It has to be pat because whenever you rub, you're rubbing off the oils off the skin.
Mm.
So that would be the big one there. And then apply, I generally like E4 or 5, I like to recommend, or and Glaxo is a little bit more of a cream, but an ointment that they can smooth on 2 to 3 times a day is quite reasonable for that particular case. But yeah, and you don't want hot baths, no hot tubs, no hot showers when they're exposed to the higher temperatures or hot bath temperatures. They're losing a lot more. The pores open up and they're losing the moisture a lot more. And I find a lot of the elderly population likes their hot baths.
Mhm.
Christina?
Oh, just one last question. Matt, is there any other medication that's associated with increased risk of skin cancer that you can think of? Now I'm thinking of all my patients, my family practice patients on HCTZ that I need to switch over.
Hydrochlorothiazide, that's the big one. But I'll have to do a literature review and I can get back to you on that. An interesting one that I've seen was on beta blockers. A very common one I actually have for family practice is I have doctors refer patients over and they have psoriasis, and I tell them that they have to come off their beta blockers, and they do, and then their psoriasis goes away. That one's interesting. Not skin cancer related so much.
Yeah.
Nothing specifically that I know related for basal cell carcinomas. One good way to actually reduce the risk is B6 of squamous cells. So that one's actually really good to reduce your risk of squamous cells, both external and internally can reduce your risk. And
vitamin B6?
Yeah.
Oh, okay.
That one, niacinamide. If you can get a topical niacinamide and they've got a lot of AKs, that reduces the risk as well.
Good to know.
And I don't know if you do general practice as well. A really good, and the patient has a lot of actinic keratoses. A good, actually even BCCs, Metvix. It's a new medication on the market, which is really interesting. And you just literally put it, a physician would apply it in clinic. And then you can do 2 options. You go out into the sun for 2 hours, then you wash it off. And it actually helps get rid of the AKs. Or you can do red light phototherapy, and it can actually treat basal cells, actinic keratoses, and a little bit more superficial squamous cells too.
So a mild version, it sounds like a milder, gentler version of 5-FU.
Way more effective because the 5-FU isn't actually that effective against basal cell carcinomas.
Right.
This one actually helps treat BCCs as well.
Interesting.
Crazy. Okay, my other lessons were don't rush. Sometimes you can just wait. Don't feel badly about calling Matt over to use his dermatoscope or his Woods light because he loves his Woods light. And don't forget to control the sugar if it's candida, and try to find some nystatin powder for all those breast
Excellent.
All right, thanks so much, Matt. That was very, very helpful.
Yeah, nice to meet you, Matt. It's great.
Nice to meet you guys too.
Thank you.
Have a good evening. Bye.
Bye.